when we've studied animals and we've kept them in a sterile bubble, they don't develop proper immune systems, and they have gone on to develop immune problems. A kid's not playing in the street and picking up pebbles and sucking on them and all the things that they used to do. This is atopy rather than autoimmunity.
Hello and welcome back to MedSynapse podcast series, where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host, Dr. Smarika Bhatt, and today we are thrilled to have a conversation between the topic microbiome and autoimmune disease, especially focusing on rheumatic conditions. We are thrilled to have Dr. Francis, a consultant rheumatologist at Mediclinic Middle East. Dr. Francis' extensive experience in rheumatology and internal medicine, with particularly interest in MSK ultrasound, connective tissue disease, and seronegative arthritis, is not just a clinician but also a passionate educator and advocate for quality improvement in healthcare. Welcome, Dr. Francis, to the podcast. We're excited to host you here.
Well, thank you very much for the invitation. Pleased to be here today.
So, without further ado, we'll start with our first question. What specific microbial signature have been identified as biomarkers for pre-symptomatic rheumatic diseases?
It's a great question. Rheumatologists deal with predominantly autoimmune disease. Appreciate that also within our field there's things like osteoporosis, metabolic disease, soft tissue rheumatism, but the most part we're dealing with problems within the immune system attacking itself. And of course, that's not the function of the immune system. It is there to provide defense against these microbes and bacteria and viruses. So it stands to reason that the study right from the beginning of rheumatology has been, well, what is it that's triggering this problem within the immune system, and infections and microbes being the big focus? Because if this was an inbuilt problem within the genetics of one's immune system, you might expect that it would be coming on a lot earlier in the development or even at birth, as some of the primary immune conditions do. And indeed, you might expect that congenital twins, for example, who share the same genetics would have identical rates of the development of these diseases. And the concept of molecular mimicry, which is to say microbes that present proteins and products that look a little bit like us, and therefore we start to think we should be attacking us because we mistakenly look at the proteins in our own bodies that are similar to the ones they're producing. That concept has been around for a while. Now, the big excitement, I suppose, has been in the microbiome and whether we can understand more about the bugs that live in our system. And again, just a reminder on the basics of that. I mean, we have billions of cells all across our skin and in our gut, more numerous in number, in fact, than the cells of our own bodies. So we are arguably more microbiome and commensals than ourselves. And these clearly play an important role in health. In particular, the microbiome, it helps us to break down products that we wouldn't otherwise be able to break down, and fibers and things. It's a university, a training ground for the immune system to recognize pathogens and commensals and learn and grow. It helps us to create vitamins and absorb certain vitamins, B12 and vitamin K in particular. It can even impact how we metabolize drugs and medications. And of course, by doing this in a healthy microbiome, it protects us against nasty pathogens. It protects the wall of our endothelial lining of the gut from things translocating into the bloodstream. So we don't want invaders, and we don't want foreign proteins getting into the bloodstream to irritate the immune system. And a healthy microbiome does this. So then that comes on to, well, what do we think is an unhealthy microbiome? Then this is the concept of dysbiosis, and that's particularly within the microbiome, but there's also been specific microbes elsewhere of interest in the study. So certain microbes like firmicutes and proteobacteria have been considered to be perhaps more of a negative microbiome or negative bacteria. Others like lactobacillus and bifidobacterium have been associated with being more positive features in the microbiome. But in particular, having a diverse microbiome is thought to be really important. So no abundance of any one particular bug and a healthy coexistence of lots of different cells. There's been studies of the human microbiome in rheumatoid arthritis. And again, these are finding similar findings about the higher abundance of proteobacteria There's a further study that looked at Preventive corpri, which seemed to be picked up earlier in very early rheumatoid arthritis cases. In the mouth, we've had a lot of interest. Obviously, that's the beginning of the microbiome, one could argue, because the mouth is also, the stomach should be relatively sterile, but the mouth isn't. And one bug in particular, called Porphyromonas gingivalis, I'll just call it P. gingivalis from now on, has been of interest. And I'll talk a bit about what goes on in there later, but it can citrullinate proteins, and we know that is related to antibodies we see in rheumatoid, which sometimes gives rise to the idea, goodness, if we can vaccinate against that, could we vaccinate against rheumatoid? But it's always more complicated than you think. We have got some sort of belief that some of these bugs that produce short chain fatty acids, and I'll come on to this question in a bit more detail next, but they may also be part of the signature in terms of being of assistance to the immune system. So a lot has been studied. Several targets have been noted. No one bacterium has been identified that you could eradicate or vaccinate against. And even with the knowledge of what these microbes can do, it doesn't fully explain everything that's happening in rheumatic conditions.
Thank you, Dr. Kynaston. That was a great insight from touching all the microbiomes in our body system. So let's move on to our next question. What do bacterial peptides cross-react with host tissue in rheumatic conditions, and what are the key mechanisms or pathways for it?
So again, I will try to provide a reasonable answer, and I will try not to delve into the deep depths of immunology, not least because I'll probably lose myself along the way. I always find it fascinating, but the number of different cross-linked pathways, it can become incredibly complicated. So the first bit I think to think about is this idea of molecular mimicry, which again, it's this concept that there's going to be similarities between invader proteins and human proteins. And I'll come on to that a little bit more when I talk about bystander activation and how that relates to some of this. So the P. gingivalis that we talked about before, that has an enzyme called PAD in it. That enzyme catalyzes an amino acid called arginine to citrulline. And those who know a bit about rheumatology will know that we commonly check for anti-cyclic citrullinated peptide, which seems to have a pathological process within the development of rheumatoid arthritis. And certainly, while it's not much more sensitive than rheumatoid factor, there's still maybe 70% of patients having that antibody. It is a lot more specific. So 95% of people with that antibody either have or go on to have rheumatoid. So there's something definitely wrong about having an anti-CCP antibody. There may be mechanisms within perhaps the enterotoxins, or perhaps the mechanism of specific bacteria, especially those that cause endothelial irritation. So here we're talking about reactive arthritis, and we know that Shigella, Yersinia, Salmonella, and Chlamydia all cause inflammation of the linings there, are more likely to cause a reactive arthritis than many other bugs. And this may not just be about how the bugs work themselves, but how they react with the host immune system. Because if you have an HLA-B27 immunogenotype, then you're more likely to get a reactive arthritis. So there's something obviously within that HLA process that doesn't work well within the way in which those bacteria produce their pathognomonic mechanisms. Within SLE, flares, so infections may cause flares of SLE, and perhaps infections may be provoking the development of SLE. And some of this may be coming from the genetic material that they carry, so viruses and bacteria, then exposing the genetic material to the immune system. And obviously the immune system is not normally exposed to the nuclei, not to mention obviously that the cells may burst and our own cells may then be exposing our own DNA to the immune system. And so you can develop nuclear antibodies and DNA antibodies, which obviously is part of the disease process. There's also toll-like receptors. Now these are basically bug receptors, pathogen receptors, and they recognize particular proteins called pathogen-associated molecular patterns, or PAMPs. So they're peptides, like a little tail of a flagellum or something. And if they get bound on the surface of cells, they release cytokines and chemokines, in other words, marching orders to go somewhere and orders to promote inflammation. So they can be one mechanism by which the immune system gets auto-activated. And then this idea of bystander activation. So B cells, we know they're made in the bone marrow, but they mature also in the bone marrow. That's where they learn their trade. And in that process of being in the bone marrow and maturing from there and going to the spleen, those that auto-react are killed. So we don't want B cells going out that are going to attack the body. But some do get through, or some may be close to reacting to the self, but not quite close enough to kill themselves. And the same is true for those T cells. So they obviously start in the bone marrow, mature in the thymus, and if they auto-react, they also should die or should be killed. But a small number may get through, a small number may be slightly off ourselves, but close enough. And then we have this molecular mimicry, where you have similar-ish proteins, perhaps similar to those that B and T cells were auto-reactive against. But they won't become activated unless they're activated by another cell called the dendritic cell, so sort of pattern recognition cell. And they get activated by an infection. So if there's an infection and you've got, let's say, a B or maybe even a B and a T cell that was slightly autoreactive, within that infection, you may get some tissue damage. And if that tissue damage affects the dendritic cell, it may take in some of your own proteins. And if that happens to be similar to what the B or T cell was autoreactive against, you can see how an infection, tissue damage, can then lead to activation of these B and T cells to start attacking yourself and producing antibodies against yourself, or if indeed the proteins are similar within the bacteria itself. And that can then go on to be perpetuated by something called epitope spreading. So if you get an activated autoreactive T cell, that can activate normal B cells, so long as there's some similarity within the peptide of what the B cells goes on to produce. It doesn't have to be an autoreactive B cell. So you can see how a small population of one line of autoreactive cells could then perpetuate an ongoing inflammatory process. And just one final bit, which was a bit sort of mechanistic about the short chain fatty acids. These we think are to do with the permeability of the gut. And so it's nice to have less permeable endothelial linings, but they also may have some regulation over subtypes of T cells. So you get different T cell types, obviously your natural killers, which is your assassin types, and your peacekeepers and regulators. And the short chain fatty acids seem to have a role in helping to regulate and settle down some of the.
We'll start with the third question. What evidence support early life microbiome perturbation, including influencing autoimmune disease, and how might interventions prevent rheumatic diseases?
I do enjoy going to a seminar and learning more about the mechanisms of rheumatoid arthritis, but really as a jobbing clinician, my interest is in, so what? What does that mean we can do differently? We know that there are differences in life outcomes depending on whether your immune system is properly trained in childhood. So a key difference, for example, would be childbirth. If you are having a cesarean section versus having a vaginal delivery, there's going to be a significant reduction in the exposure to the microbiome. Obviously, you do not want a C-section to not be sterile. You don't want to introduce bugs into the abdominal cavity. But that has shown that you have a greater risk of developing a number of conditions, amongst which are autoimmune complaints such as diabetes, mellitus 1 and rheumatoid arthritis. Moving on from there, you have risks that increase if you're not given breast milk. Now, obviously not everybody can breastfeed, but in every situation where you can, it is far better that you do, because child's immune system is still immature. They're not going to be producing proper antibodies. They've not been exposed. Their immune system hasn't learnt how to cope with things. That immunity, that passive immunity, already helps, but also breastfeeding is not sterile, whereas bottle feeding is sterile. So there's microbiomes on the skin, and that's going to produce some learning and some translocation of healthy microbiome from mother to child. When we've studied animals and we've kept them in a sterile bubble, they don't develop proper immune systems, and they have gone on to develop immune problems. So clearly there is a purpose for our immune system, and it doesn't like to be left dormant. When we've studied children who have juvenile idiopathic arthritis, which is any form of the inflammatory arthritis under the age of 16, we've seen again some of these pro-inflammatory bacteria, and we've seen again a lack of diversity. So this idea that it's not just an association, but actually it seems to be that this is really promoting the right conditions for the immune system to become auto-reactive. So this has kind of led to people asking, well, are we washing our hands too much? Kids not playing in the street and picking up pebbles and sucking on them and all the things that they used to do. And you see that with some of the other, this is atopy rather than autoimmunity. But eosinophils, for example, don't have a function that much, particularly in the Western world, because they are there for parasites and helminths and worms and things that we don't really see that much of. We see a lot of asthma and eczema. By contrast, they are kept more busy, and there's a lot less asthma and eczema, for example, in Africa. And perhaps there's this need to be doing the tasks that you were designed to be doing. Otherwise, simplified way, and I like simple things, you're going to get bored and then start creating trouble. And of course, we do give people antibiotics. We've got lots of antibiotics, and we know that's not helpful. And there's evidence that there's clearly something environmental, because when you have twins, you can see different rates of autoimmune conditions onset. And so there must be something different in their environment. Now, it might be that they're smoking. That's obviously one of the things, although smoking can also affect the microbiome in the mouth. But it could also be the way in which they've lived their life. So I think it was mainly those are the evidence bits, wasn't it? Because you wanted to then ask about what do we do?
And that was a wonderful answer. I'm sure our audience will get a great insight from it. So let's move on to the last question for our podcast interview. So that is, how can microbiome profiling be integrated with genetics and environmental and immunological factors for personalized rheumatic disease prevention?
Yes, thank you. Well, so many of the conditions in rheumatology are heterogeneous. So rheumatoid arthritis, for example, we can give people drugs that affect the innate immune system, drugs that suppress B cells, drugs that suppress T cells, and they all work. Drugs that suppress certain cytokines. So it's a complicated condition, and lupus is a really great example of how complicated it is and how difficult it is to get new drugs into that space, because the types of outcomes in lupus are so varied that it makes it very hard to study for drugs, because are you looking at the lupus nephritis, or you're looking at the skin disease, or you're looking at CNS disease. So there's a lot of heterogeneity in the way in which these conditions present, even within our patients. And so there's a generic advice you could give about the microbiome, which we hear a lot about, and I will still go over it today. And then there's targeted advice. So generic advice is have a healthy microbiome and do everything you can to have a healthy microbiome. And this applies whether you have a risk of autoimmunity in your family or not. So if you were planning to have a child and you want to give them a healthy microbiome, you would aim, if possible, to have a vaginal birth. You would aim, if possible, to minimize the courses of antibiotics when you're carrying the child. You would aim to breastfeed the child, and you would aim to expose them early on to a little bit of microbes, not too much, and to a wide variety of pro and prebiotics. So that's helping to create the conditions for a healthy gut. So we know that the more varieties of fruit and veg, so they say about 30 different varieties in a typical week, because each of those provide a little bit of a different nutrient source for a little bit of a different part of this diverse microbiome that we want. We can also promote that by having fermented products like kimchi, sauerkraut, kefir, yogurts. Those are helpful. Avoiding toxins, avoiding sugars, toxins, things like alcohol and smoking. But you could argue that processed food and sugars is a kind of a toxin. If something is on the shelf and is in a wrapper and is going to stay on the shelf and be fresh in a couple of weeks' time, something is in that to prevent bugs and microbiome growing. And if you then ingest that, that may not be helpful for your own microbiome. And that's before we consider the other impacts, the metabolic impacts. If you take an apple and you eat it, you have to then digest the pieces of that apple, and it will slowly come on as an incident spike from the glucose. If you blend it and drink it, you're going to get a much quicker spike. You're going to get a lot less of that roughage and protein and surfaces for the bacteria to grow on. Most of our food is slightly processed, and if you have a steak and you cook it, that is still slightly processed. But it's these ultra processed foods, soft drinks, those sorts of things that are particularly worrisome. But can we screen people? Can we use what we've learned, the microbiomes that we spoke about earlier, to screen people? I don't think we can really do that on a population basis. I think, firstly, the science is not far enough along. Secondly, it would be prohibitively costly to screen everybody. And also, how do we know that if you're not at risk, just because we see these bugs in the populations who get rheumatoid, how do we know that there's loads of people out there that have those bugs that are absolutely fine? They just didn't have the genetic risk. And there's some research, but I think on a population basis, certainly not enough to account for that. But I think if you had a history where your mother, your father, your aunt or something had rheumatoid or lupus, you might want to know if your microbiome is good. You might want to be tested for those sort of things. And in the future, we might be able to intervene. And of course, there are other things that you can do, perhaps not the most palatable, but you can do fecal transplants via a tube. So you can literally infuse the right kind of bacteria into someone's gut. And perhaps that might be more useful in elective situations. So someone is going in for joint surgery because of their rheumatoid. We're going to want to make sure they don't get an infection in the joint. So they give us their feces, and then they have their antibiotics, and then you could do a fecal transplant to sort of bring back their pre-operative gut microbiome, so that they're not getting a worse risk of flares or problems because we had to give them antibiotics afterwards. And now the reason why it's important, I think, to think about this and to think about personalized medicine and also early intervention is, in rheumatology, we know intervening early is good. So all the evidence is don't wait. We used to say, start low, go slow with methotrexate many years ago. Now we know you have to go in early, you have to go in heavy with this. As biologics become cheaper, we're starting to use those earlier. And we've seen in some studies like the trials that potentially, if we go in a pre-symptomatic phase with T-cell treatment, for example, we can almost stop them from getting the condition. So if someone turns up and says, my mum's got rheumatoid, I've got not many symptoms, but I have got these antibodies, you might prevent them from going on to have rheumatoid arthritis that way. So I think the future's quite exciting.
Okay, so that was a really incredible answer. You shared the insight in a deeper level, in a personal touch as well. And we are thrilled to host you today, and thank you for joining in. It was a pleasure to have a conversation with you. And thank you to our viewers for tuning in. And remember, if you are a healthcare professional who is eager to dive deeper into medical topics or have questions, do not hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, or contribute to the ongoing evolution of healthcare. So until next time, take care. Thank you.